Good evening, guys. I have discussion C for you. We're discussing the key distinctions between comfort care and hospice care. Okay. Those are two different things, but they do basically the same thing for a person that's dying. So we're going to go through what each of them is for tonight's C. So please join me for discussion C. Okay, here we go. Here's a breakdown of the key distinctions between comfort care and hospice care as outlined in the article. Comfort care, palliative care, focus, relieves pain, symptoms, and stress of serious illness, whether or not it's terminal. Okay, eligibility. Anyone with a serious illness, regardless of life expectancy. Treatment can be combined with creative or life-ending treatments, life-extending treatments. Services, pain and symptom management, treatment options, and community resources. Duration, unlimited and can be adjusted as needed. Okay, insurance may be covered by private plans. Public coverage varies. Location, available in homes, hospitals, nursing homes, assisted living, or palliative care facilities. Focus holistic support during the terminal phase of illness, typically 6 months to live. Eligibility, terminal diagnosis certified by physician. Okay. Treatment begins when creative care treatments are no longer beneficial. Services 24/7, pain and symptom management, plus bereavement and counseling. Okay. Duration, usually up to 6 months with possible extensions. Insurance, often covered by Medicare, TRICARE, and VA, and some Medicaid programs. Location, some same as comfort care with the addition of hospice specific facilities. Both approaches aim to improve quality of life, but hospice is reserved for end of life care, while comfort care can be integrated earlier and alongside active treatments. Would you like to explore how these models could be adapted for culturally responsive or community-based frameworks? Absolutely. Hospice care is deeply compassionate model designed to support individuals in final phase of terminal illness when creative treatments are no longer effective or desired. Here is a more detailed look at its core components. What is hospice care philosophy? Hospice prioritizes comfort, dignity, and quality of life over creative treatments. It's not about giving up, it's about shifting focus to what matters most in someone's final days, months. Okay, folks. Eligibility. Typically, for patients with a life expectancy of 6 months or less, certified by 2 physicians. Common conditions include advanced cancer, dementia, heart failure, ALS, and more. Care settings delivered wherever the patient calls home, private residence, nursing home, assisted living, or nursing home, or hospice center. Some people want to die in a home-like setting, but they don't want to die at home. Some people go to hospice centers to pass away. And that's everybody's, it's up to the individual. Basically, they have the say so as to how they want to run their care for hospice and palliative care, folks. Okay, assisted living or hospice facility. The goal is to keep the person surrounded by familiar people and things. Interdisciplinary team. Hospice care is holistic and team-based. Physicians, nurses manage pain and symptoms. Social workers support emotional and logistical needs. Chaplains offer spiritual care regardless of faith traditions. Home healthcare aides assist with daily tasks like bathing, dressing. Volunteers provide companionship and respite. Okay, bereavement counselors support families during and after the loss, often up to a year. That's why, like I said earlier, we in hospice care give the family support after they pass for 6 months. Guys, it's called aftercare. 6 months of aftercare. That means if someone wants to sit on the phone with us and have a conversation about how they feel for the day, that's their right for 6 months. If they need our support, our job is to be there for them for 6 months after their loved one dies. We stress that in the middle of their care also when we begin. We're upfront with what we do, things like that, things of that nature. So, with that being said, next page. 24/7 support, on or on call, help for crisis or symptom management, advanced care planning, guidance on living wills, DNRs, and end of life wishes, respite care, temporarily facilitated or facility based care to give family caregivers a break, emotional and spiritual support for both patient and family members, tailored to cultural beliefs and personal preferences or values, coverage and costs, Medicare, Medicaid fully covered hospice services under specific conditions, private insurance. Most plans offer partial or full coverage, no out of pocket surprises for hospice teams, help navigate financial logistics. What hospice is not. Hospice, it's not about hastening death. It doesn't replace family caregiving, but supplements it. It doesn't provide 24/7 bedside care unless medically necessary, e.g., conscious continuous home care or inpatient hospice. Would you like to explore how hospice models could be adapted for rural or culturally specific communities like these, like those we've discussed in your toolkit work? There's a rich potential for participatory redesign. Absolutely. The distinction between hospice and palliative care aren't just uh, somatic, they shape how individuals and families navigate serious illness, make decisions, and access supports. Here's why these differences matter, especially in the context of equity, cultural responsiveness, and systematic or systems level design. Timing impacts trajectory. Palliative care can begin early in the illness, allowing for proactive symptom management, emotional support, and care planning. Hospice care enters later, often when creative options are exhausted. Delayed referrals can mean missed opportunities for comfort and closure. Why it matters: early access to palliative care can reduce hospitalizations, improve quality of life, and empower families, especially in underserved communities where late stage interventions dominates. Treatment goals shape expectations. Palliative care supports both healing and comfort, helping patients maintain hope while managing symptoms. Hospice care shifts fully to comfort and dignity, helping families prepare emotionally and spiritually for the end of life. Why it matters. Clear communication about goals prevents confusion, reduces moral distress, and aligns care with cultural values, particularly in communities where death is stigmatized or misunderstood. Eligibility criteria affect access. Palliative care is, is broadly accessible but often underutilized due to lack of awareness or systematic barriers. Hospice care requires a terminal diagnosis and a decision to stop creative treatments, which can be emotionally and culturally complex. Why it matters. Marginalized populations may mistrust systems of delay hospice enrollment due to stigma, spiritual beliefs, or lack of culturally tailored outreach. Understanding these thresholds helps design better engagement strategies. Okay, guys, so that is it for tonight. I will see I will see you guys for shows tomorrow. For now, Gator Wellness, take care, folks.